Welcome to this deep dive to help get you ready for the FRCS plastic surgery exam. We'll be focusing on rhinoplasty, covering the essentials like anatomy, key surgical techniques, and those potential complications you got to watch out for.
Okay, so let's jump right in with the nasal anatomy. Got to know that inside and out, right?
Absolutely. So first up, that skin envelope, right?
Mhm.
How does the thickness change across the nose, and why is that so important, surgically speaking?
Good question. The skin on the upper two-thirds, that's thin, pretty mobile, but when you get to the lower third, that skin, it gets thicker, less mobile.
And why does that matter, like when you're planning a surgery?
It affects how that skin drapes, over the structures underneath. You really got to factor that in when you're planning your moves.
Makes sense. Okay, moving on to muscles then. Which ones are the key players in rhinoplasty, and what do they actually do?
So there are three muscles you really need to know for the FRCS. The levator labii superioris aliquinasi, that one helps keep that external nasal valve open. Then there's the nasalis muscle, that's involved in making sure the airway's patent. And finally, that depressor septi, that can actually affect the tip projection and how long the upper lip looks.
So how would that depressor septi, how could that mess things up in rhinoplasty?
Well, if it's overactive, it can pull the tip down and make the upper lip look shorter. Dividing it during surgery, that can help with tip projection and even out any asymmetry in the upper lip.
Got it. Okay, blood supply to the nose. What arteries do we absolutely need to know for rhinoplasty?
Most of the blood comes from branches of the ophthalmic and facial arteries. It's really, really important to understand their course, where they go, to avoid complications during surgery.
Can you break down those branches and why they matter?
Sure. So from the ophthalmic artery, you've got the anterior ethmoidal artery, the dorsal nasal artery, and the external nasal artery. Those supply the upper part of the nasal envelope. The facial artery, that's super important. It gives rise to the superior labial artery and the angular artery. They supply most of the nasal envelope, including the tip.
You mentioned the lateral nasal artery being particularly important, right? Why is that?
Yeah, so that lateral nasal artery, it comes off the angular artery, and it's like the main blood supply to the tip in open rhinoplasty. That's because we sacrifice the columellar arteries in that approach. If you damage the lateral nasal artery during dissection, you risk soft tissue necrosis. Not good.
Definitely not. Okay, let's talk about the nerves in the nose. Which ones provide sensation, and how does that play into surgery?
The nose gets its sensation from branches of the trigeminal nerve, specifically the supraorbital supratrochlear nerves, and also the external nasal branch of the anterior ethmoid nerve. Knowing where they are, it helped us minimize trauma during surgery.
Now let's talk about the structure of the nose itself, the framework. What are those nasal vaults, and how do they contribute to the form and function?
We can divide the nose into three vaults, upper, middle, and lower. Each one has its own features and important clinical implications, things we need to think about.
Okay, let's start with the upper vault then. What are the key things to consider during rhinoplasty?
The upper vault is the bony part, made up of the paired nasal bones and the ascending frontal processes of the maxilla. Those nasal bones, they can vary in thickness and density, thicker at the top.
Why does the thickness matter?
Well, if you're doing osteotomies and you do them in the thicker part, you can get a complication called rocker deformity, so you got to be aware of that.
Okay, I see. What about the middle vault then? What's important there?
The middle vault's got those paired upper lateral cartilages, the ULCs, and also the dorsal septum with their soft tissue attachments. The ULCs join the septum to make the internal nasal valve, that's the narrowest part of the airway. And then there's the keystone area, that's where the bony upper vault meets the middle vault. That's super important for support.
What about the lower vault then? The lower vault. What structures affect the tip projection, rotation, and definition?
The lower vault, that's all about those lower lateral cartilages, the LLCs. They control the shape and support of the tip. If you want to do any tip refinement, you really got to know your LLCs.
Right, makes sense. So what are the key factors then for tip support and projection?
Five main things. You've got the LLCs and how they attach to the piriform aperture. Then there's the domal suspensory ligament, those fibrous connections between the ULCs and LLCs, the medial crural ligaments, and finally the anterior septal angle. They all work together to keep the tip stable and in the right spot.
All right, that's a lot to remember. Let's talk about the nasal septum. What are the big things for rhinoplasty?
So the septum, that divides the nasal cavity, right? It's made up of the quadrangular cartilage and bone from the ethmoid and vomer. It can be pretty variable in its anatomy, especially where the cartilage and bone meet.
And what do we need to be looking for when we examine the septum?
You're looking for any deviation, perforation, or bone spurs. Those can all mess with nasal function, and you have to factor them into your surgical plan.
What about if the patient has had some trauma to the septum in the past?
Yeah, that can cause specific fracture patterns that affect the biomechanics, how the septum works. You might need special techniques to fix those.
Gotcha. Okay, onto the turbinates. What's their function and why are they important in rhinoplasty?
The turbinates, they're like paired structures on the side wall of the nose. They help humidify and filter the air we breathe in. There are three types: superior, middle, and inferior.
Which one are we most interested in for rhinoplasty?
The inferior turbinates, those are the biggest ones. They're the ones that can cause problems with nasal airway resistance.
What's the connection between a deviated septum and those inferior turbinates?
If you've got a deviated septum blocking airflow, the inferior turbinate on the other side can get bigger to try and compensate, but that can just make the obstruction worse.
So if someone's got really big turbinates, can we just take them out?
Whoa, careful there. If you remove the whole inferior turbinate, you can end up with empty nose syndrome. That's where the nose is constantly dry and feels blocked even though it's open. You want to preserve as much of the turbinate as possible.
Okay, good to know. Let's talk about the internal nasal valve now. What is it and why is it such a big deal for breathing?
That internal nasal valve, it's the narrowest point in the airway. It's formed by the angle between the ULC and the septum. It controls the airflow, and a lot of the resistance comes from there.
So what's a normal angle for that valve and how do you check it?
You want it to be between 10 and 15 degrees. If it's narrower than that, it can restrict airflow. We use the Cottle maneuver to see if it's collapsing. You gently pull the cheek outwards and see if the airflow improves.
What if it's collapsed? How do you fix it?
We use spreader grafts. They go between the ULC and septum to open up that angle and improve the airflow.
Okay, what about the external nasal valve then? How does that work?
The external valve, that's mainly formed by the lower edge of the lateral crest of the LLC and the nasal septum. The soft tissue of the ala and the nasal sill, those also play a role.
How do you know if it's not working properly?
You look for any nostril collapse when the patient breathes in. That can mean the support structures are weak.
And what kind of things do people do to try and compensate if the valve's collapsed?
You might see some alar rim notching or the rim turning outwards when they breathe in, trying to open up the nostrils.
Interesting. Okay, let's move on to how the nose actually works, the physiology. How does it affect airway resistance and what factors are involved?
The nasal airway, that accounts for about half of the total resistance to airflow. The lining of the nose, the mucosa, that can get swollen and really reduce the space for air to flow through.
So even small changes can make a big difference then.
Exactly. There's this thing called Poiseuille's law, and it basically explains how even tiny changes in the radius of the airway can have a huge impact on how easily air flows through.
What happens to the airway when we breathe in? Does it change?
Yeah, when you breathe in, you create negative pressure, and that actually makes the internal nasal valve narrower because the ULCs move closer to the septum. But at the same time, the nostrils expand to let more air in. It's a pretty complex system.
It is. What about that nasal cycle you hear about? How does that work?
So the nasal cycle, that's a natural thing where the mucosa on one side of the nose shrinks while the other side swells up. It switches back and forth every few hours. It's something to think about because surgery can mess with this balance.
Okay, that makes sense. Let's talk about nasal obstruction now. What causes it and how do you figure out what's going on?
It can be caused by anatomical problems like a physical blockage or physiological issues like problems with how the nose functions. If someone's always got a blocked nose, that usually points to something structural, like a deviated septum.
What if it's been getting worse over time? What could that be?
If they're a smoker and they've been having nosebleeds, it could be a sign of something growing in there.
Are there any other presentations that give you clues?
Oh yeah, definitely. If it's seasonal or triggered by allergies, that's classic allergic rhinitis. If both sides are blocked and it comes and goes, that usually means there's some kind of mucosal problem.
How do you sort all that out?
A good history, a thorough physical exam, and sometimes using a vasoconstrictor to shrink the lining of the nose can help you pinpoint the cause.
So how do you treat it then?
Well, it depends on what's causing it. For allergic rhinitis, you avoid allergens, control the environment, and maybe use medications like antihistamines or nasal steroids.
What about if it's a virus?
Viral rhinitis, that usually goes away on its own. You can just treat the symptoms and make the patient comfortable.
What if it's caused by medication?
Rhinitis medicamentosa. That's from using decongestants too much. You need to get them to stop using those and give them some good education on how to avoid it.
Before you jump into surgery for obstruction, are there any red flags you need to check?
Absolutely. You got to rule out any underlying medical conditions. And You also need to be aware of things like MRSA colonization. You have to manage that before you even think about surgery.
Good point. Okay, so we've covered the basics of nasal anatomy and physiology. Let's talk about nasal analysis and how we plan for surgery. What's the key to communicating effectively with rhinoplasty patients?
You got to understand what the patient's goals are, what they're hoping to achieve. And you need to be sensitive to any cultural differences in what people find aesthetically pleasing. You have to be upfront about what's possible with surgery.
How do you make sure everyone's on the same page?
Using imaging technology can help, like computer simulations that can give patients a visual idea of the potential outcome. And you always have to be upfront about the limitations and potential risks.
Okay, so what are the essential views you need to assess the nose properly?
You need to look at it from 3 angles: front, side, and underneath. That way you can do a complete analysis of the face, the skin, any asymmetry, and all the important landmarks.
So let's start with the front view. What do you look for there?
In the frontal view, you're looking at the overall face, how thick and what quality the skin is, any deviation of the nose, those dorsal aesthetic lines, the width of the upper vault, how the middle vault looks, the width of the alar base, how defined the tip is, and the characteristics of the infratip lobule.
Can you explain those dorsal aesthetic lines? What are they and why are they so important?
The dorsal aesthetic lines, they should be gently curved and going outwards, from the medial brow ridge to the tip defining points. The shape and symmetry of those lines, they really affect the overall harmony of the nose.
How do you assess the upper vault width in relation to the alar base?
Ideally, the bony vault width should be about 75% to 80% of the ideal alar base width. And you check for any irregularities, like that inverted V deformity where the middle vault joins. You also look for any collapse or odd contours in the lateral nasal walls.
Okay, and what about the alar base? How do you know if it's too wide and whether the problem is flaring or just a wide base?
You compare the widest part of the ala to the width at the alar base. If the difference is more than 2 millimeters, that suggests flaring. If it's less, it means the base itself is too wide. And you look at the shape and symmetry of the rims, too.
When you're looking at the nasal tip, what are the ideal characteristics? And how do you spot potential problems?
The tip should be where those dorsal aesthetic lines meet, with 2 distinct tip-defining points and symmetrical light reflexes. A well-defined tip makes a diamond shape when you connect the key landmarks. If it looks bulbous or boxy, that could mean the cartilages are out of place.
What about the infratip lobule? How do you assess that from the front?
You look for any fullness or asymmetry. Ideally, if you draw a line through the apex of the nostril, it should cut the infratip lobule in half.
Right, makes sense. Let's move on to the side view then. What are the key things you're analyzing there?
So from the side, we're looking at the radix position, the slope of the dorsum, the tip projection, the tip rotation, the contour of the ala, how much columella you can see, and the characteristics of that infratip lobule again.
Can you talk about what the radix and dorsal slope should look like ideally?
Their radix, that should be level with the upper lash line or the supratarsal fold. If it's too low, the nose can look like it's sticking out too much. The dorsal slope, it should be straight in men and slightly concave with a little break at the supratip in women.
How do you assess tip projection, and how does that relate to other measurements?
Tip projection is the distance from where the ala meets the cheek to the tip of the nose. It should be about 67% of the total length of the nose, and roughly the same as the width of the alar base.
Yeah.
We also look at how much of the tip projects in front of a vertical line that touches the upper lip.
What about the rotation of the tip? How do you measure that?
We use the nasolabial angle for that. It's the angle between the columella and the upper lip. For women, the ideal angle is between 95 and 110 degrees. For men, it's a little narrower, 90 to 95 degrees.
What are you looking for when you assess the alar contour from the side?
You want the alar rim to have a smooth oval shape, and you want to see about 2 to 3 millimeters of the columella.
And lastly, the infratip lobule. What are you checking for from the side view?
We look at the columellar labial angle that should be between 30 and 45 degrees. If there's fullness in that area, it usually means the caudal septum is sticking out too much.
Okay, last view then, the basal view. What are we looking for there?
From underneath, we assess the shape made by the alar rims and the tip, the shape of the nostrils, and the border of the columella. We also check for any distortions caused by septal deviation, excess medial crura, or fullness in the soft tissue.
What should the nostrils and columellar border look like ideally?
The nostrils should have a subtle teardrop shape, with the point slightly inwards. The columellar border should be smooth and well-defined, so the base of the nose looks balanced.
Before we move on to surgical techniques, let's quickly go over graft nomenclature. What are the main types of grafts used in rhinoplasty?
We categorize grafts by location. So there's nasal dorsum grafts, nasal tip grafts, nasal ular grafts, and ular base grafts. Each one has a specific job in reshaping and supporting different parts of the nose.
Okay, let's talk about the two main surgical approaches now, closed and open. What are the pros and cons of each?
Closed rhinoplasty, also called endonasal rhinoplasty, that's where all the incisions are made inside the nose. The advantage is there's no external scar, the dissection's limited, and recovery can be faster.
What's the catch then?
It's harder to see what you're doing, so it's more technically demanding, and it's not really suitable for complex cases.
What about open rhinoplasty then?
Open rhinoplasty, that involves making an incision across the columella. That way you can see all the structures directly.
Sounds more straightforward.
It is, you get great exposure, so it's ideal for complex grafting and revision cases. But of course, you do end up with an external scar, and the recovery time might be a bit longer.
Makes sense. Okay, let's get into some specific surgical techniques now, starting with the nasal tip. What affects tip projection, and how can we change it surgically?
Tip projection depends on the cartilage and the soft tissues. You can increase it with suture techniques like medial crural, interdomal, transdomal, and medial crural septal sutures. Or you can use cartilage grafts like columellar struts, septal extension grafts, or tip grafts.
How do those sutures work? Do they just lift the tip up?
They can increase projection by a millimeter or two, and they help refine the definition by adjusting the position of the LLCs.
What about those cartilage grafts? When do you use those?
Columellar strut grafts, those are often used in open rhinoplasty to maintain or increase projection. Septal extension grafts, those are great for controlling projection, rotation, and tip support. Tip grafts, those are usually saved for cases where sutures and the other grafts aren't enough.
How do you decrease tip projection then?
You need to shorten or reposition the tip cartilages. You can do that by releasing the soft tissues, cutting the cartilage, or a combination of both.
I've heard about this tripod model. What is that?
Yeah, the tripod model, that helps you visualize the LLCs as a tripod. Shortening the lateral crura rotates the tip up and reduces projection. Shortening the medial crura rotates the tip down and also decreases projection. And if you adjust both crura equally, you just decrease projection without changing the rotation.
What happens if you set the tip back too far?
You can end up with a volar base flaring, which you might need to correct afterwards.
Okay, so how do you adjust the rotation of the tip both upwards and downwards?
To increase rotation, you can use sutures to suspend the LLCs, or you can use cartilage grafts like cephalic trims or columellar struts. To decrease rotation, you can release the LLCs, take out some of the caudal septum, or use grafts to hold the tip in its new position.
What if the tip is boxy? How do you fix that?
Boxy tips are classified into 3 types based on the angle and the width of the domes. You correct them by trimming the cartilage, using sutures, and grafting, depending on the specific type of deformity.
Are there any newer suturing techniques that are helpful for getting the tip just right?
Yeah, Tebbets has a 4-stage approach to tip suturing that addresses different aspects of shaping and positioning the tip. And Guaron and Beimon, they've described 9 commonly used tip sutures. Each one has a specific effect on the shape and projection.
Okay, let's move on to the nasal dorsum now. How do you go about reducing a dorsal hump, and what are the key things to remember?
You usually do that before taking any septal cartilage or working on the tip. We use rasps and osteotomies to carefully reduce the hump, making sure it's symmetrical.
What are the risks with hump reduction?
The big one is creating an inverted V deformity. That's where the nasal bones separate from the ULCs. It's more common if the nasal bones are short. You need to make sure the ULCs are in the right position so the nasal valve keeps working properly.
What if you end up with a gap between the nasal bones? What's that called?
That's an open roof deformity. You can fix that with osteotomies or grafts to close the gap and give the dorsum some support.
Can you walk us through the steps for component dorsal hump reduction?
Sure. First, you separate the ULC from the septum. Then you reduce the septum and then the bony dorsum. You check that everything's symmetrical, make any final adjustments, and if you need to, you can put in a ULC tension-spanning suture.
If you need to build up the dorsum, what are your options?
Cartilage is your go-to for dorsal augmentation. Septal cartilage is the best if you have enough. You can also use ear cartilage or rib cartilage, but they each have their pros and cons.
What are the downsides of using rib cartilage?
Rib cartilage can warp, which can change the shape of the nose. You can minimize that by carving it carefully, placing the concave side down, or using percutaneous K-wires to hold it in place.
Are there any synthetic implants used for this?
Yeah, sometimes we use synthetic implants like silicone, Gore-Tex, Medpor, or Dacron, but they come with a higher risk of complications compared to using your own cartilage.
Let's talk about osteotomies now. They're crucial for reshaping the bony framework, right?
Yeah.
What do you need to know to do them safely and effectively?
Control, control, control. That's the most important thing with osteotomies. You can use different techniques like percutaneous or endonasal approaches, continuous or discontinuous cuts. It all depends on what you're trying to achieve and the anatomy.
What are the main types of medial osteotomies?
The most common ones are medial, oblique, and paramedian osteotomies. They're mostly used to narrow the bony vault, but you can also use them to widen it in some cases.
When do you do the medial osteotomies compared to the lateral ones?
You always do the medial osteotomies first. That creates a stable base for the lateral osteotomies. If you do them the other way around, the nasal bones can move around too much.
Okay, so when do you need lateral osteotomies and how are they categorized?
You use them to narrow a wide dorsum, reposition bones that are asymmetrical, or close an open roof deformity. We classify them by how high they are in relation to the maxilla. Low, high, low, low, and double-level osteotomies.
Can you describe how you do a lateral osteotomy?
First, you inject local anesthetic with epinephrine. Then, you use a 2 mm osteotome to make an initial cut at the lower edge of the eye socket and the nasofrontal junction. You carefully guide the osteotome down the side of the nose, making multiple cuts, but leaving a little bridge of bone between each one. Once you've done that, you gently reposition the bones.
Are there any situations where you wouldn't do lateral osteotomies or you'd be extra careful?
Yeah, you need to be cautious if the nasal bones are thin, if the patient wears heavy glasses, if they naturally have a low, wide nose, or if their nasal bones are short. Osteotomies can be trickier in those cases, and there's a higher risk of complications.
What are some tips for staying in control and avoiding complications?
Never do osteotomies right on the anatomical suture lines. That's where the bone is thickest. And when you're using the osteotome, angle it so only one edge is touching the bone. That way you concentrate the force and have more control.
Okay, good tips. Now let's talk about the ala. How do you deal with alar rim deformities?
Alar deformities, those can be congenital or acquired, like if too much of the lateral crura was removed in a previous surgery. We use non-anatomical alar grafts to support the rim. Alar contour grafts and lateral crural strut grafts, those are the most common ones.
When do you use alar contour grafts and when do you avoid them?
You use them if there's not much loss of the vestibular lining and at least 3 mm of the LLC is left. If there's a lot of lining loss or scarring, they're not a good option. Make a pocket above the rim and insert a carefully shaped cartilage graft to fix the notching.
What about lateral crural strut grafts? When are they indicated?
You use those for things like a boxy tip, malpositioned lateral crura, alar retraction, or concave lateral crura. They go under the vestibular skin and are secured with sutures. They support and reshape the lateral crura.
Is there anything specific you do at the end of the surgery to make sure the alar rim looks good?
Always check the basal view to see if there's any notching. If there is, fix it right away with an alar contour graft.
Okay, let's talk about wide LA now. How do you approach flaring versus a base that's just too wide?
For flaring, you take out a wedge of tissue, but leave the alar base intact. You don't want to cut into the vestibule. For a wide base, you remove the whole wedge, going into the vestibule and using a specific blade angle to prevent notching.
What's the halving principle and how does that apply to closing the incision?
The halving principle, that just means you adjust the closure to account for the difference in length between the incisions on the alar groove and the alar surface.
What's important to remember about how resecting the alar base affects projection?
When you resect the alar base, it changes where the ala meets the cheek, and that can affect how far the nose looks like it projects. You got to think about that when you're planning the surgery.
Okay, let's move on to techniques for dealing with airway problems. First up, the deviated septum. What are the different ways to fix it, and how do you choose the best approach?
You can correct a deviated septum with either open or closed techniques. Open rhinoplasty gives you direct access, while closed uses incisions inside the nose, like the hemitransfixion or Killian incision. The best approach depends on how bad the deviation is and what the surgeon prefers.
So once you've got access, how do you actually fix the cartilage and bone?
You can cut out the deviated part, score and suture the cartilage, or use struts to straighten it. It's really important to preserve that septal L strut, otherwise the nose can collapse. When you're removing bone spurs, you have to be careful not to damage the skull base.
What about the mucosal flaps?
You put them back against the septum using splints, sutures, or packing. Be careful, though, if you get tears on both sides in the same place, you can end up with a septal perforation.
What about turbinate hypertrophy? How do you decide if you need to operate?
After you've straightened the septum, You check the turbinates to see if they're still enlarged. If they are, you can do an outfracture where you break the turbinates and move them outwards, or a submucosal resection where you remove some of the bone but leave the lining intact.
What's the most important thing to remember when you're operating on the turbinates?
Don't take out too much of the inferior turbinate or you'll cause empty nose syndrome. You want to leave as much healthy tissue as possible.
Let's talk about the nasal valves now, both internal and external. How do you manage problems with those?
For the internal valve, the goal is to widen the angle between the ULC and septum. We usually use spreader grafts for that. For the external valve, you want to strengthen the LLC and the ala and clear any blockages. You can use grafts, sutures, fixed septal deviations, or a combination of those things.
Can you explain the 5-step medial crural footplate modification technique?
Sure. You mark the splayed footplates, remove a strip of mucosa, put in horizontal mattress sutures to hold the medial crura together, and then close the mucosa. That helps stabilize the footplates and improve the function of the external valve.
Now, what about correcting a deviated nose? What causes that, and how do you fix it?
A deviated nose can be caused by a deviated septum, forces that deform the ULC, or asymmetrical nasal bones. To correct it, you need wide exposure, you have to release any attachments, straighten the septum, deal with any turbinate hypertrophy, and then address those asymmetrical nasal bones.
How do you straighten the septum as part of that?
You try to put the caudal septum back on the nasal spine. If you need to, you can do things like vertical sectioning, cartilage scoring, or full thickness cuts, but you always have to preserve that dorsal L strut to prevent collapse.
What about those inferior turbinates?
When you straighten the septum, it can actually make the airway narrower, especially if the turbinates were already enlarged. You might need to do a submucosal resection to prevent breathing problems after surgery.
And finally, how do you deal with asymmetrical nasal bones?
You start by rasping the bones to try and make them symmetrical. If that's not enough, you do osteotomies. If the bones are symmetrical, you usually just need lateral osteotomies, but if they're asymmetrical, you might need medial osteotomies as well.
Now let's talk about secondary rhinoplasty. That's got to be more challenging than the first time around. What are the main issues you encounter?
Secondary rhinoplasty is definitely tougher because you've got scar tissue, grafts from the previous surgery, and you might not have much cartilage left to work with. The common problems are things like residual bony deviation, collapse of the middle vault, visible grafts, tip deformities, and notching or retraction of the ella.
How do you decide how much to reconstruct the LLCs?
It depends how bad the deformity is. You often need tip grafts in secondary cases to reshape the pip and make up for any cartilage loss.
Welcome back to our rhinoplasty deep dive, getting you ready for that FRCS plastic surgery exam. This time, we're tackling those tricky complications, how to handle them, and keep your patients happy.
Complications, right. You got to know how to deal with them. We can divide them into early and late, each with its own challenges.
Let's start with the early ones.
Yeah.
What are the most common ones we should be ready for?
Early on, you're mainly dealing with swelling, bruising, pain, the usual stuff. And sometimes nasal obstruction. It's usually just the normal inflammation after surgery.
Why does the nose get blocked sometimes after surgery, and what do you do about it?
It could be swelling of the mucosa, a septal hematoma, or even just things getting moved out of place. Septal hematoma, you got to catch that early and drain it, otherwise the cartilage can die and you're in trouble.
Okay, good to know. Let's move on to late complications then. These are the ones that can pop up weeks, months, even years later. What are the main categories we need to be aware of?
We can think about them in terms of where they happen: the septum, the tip, or the dorsum. Each one has its own ways of showing up and different ways to manage them.
Let's start with septal complications then. What are the usual suspects?
The big three are septal perforation, deviation, and saddle nose deformity. Any of those can really mess with how the nose looks and works.
What causes septal perforation, and how do you fix it?
It can happen from trauma, infection, or taking out too much cartilage during surgery. Small perforations might not even cause symptoms, but bigger ones can cause whistling, crusting, and trouble breathing. How you manage it depends on the size and where it is. Sometimes you can get away with conservative treatment. Other times you need surgery to repair it.
What about septal deviation? Why would it come back after surgery, and what do you do?
If the septum wasn't properly stabilized during the first surgery, it can deviate again. That can block the airway and might need another surgery to straighten it out and make it stable.
What about saddle nose deformity? What is that exactly?
That's when the bridge of the nose collapses. It gets this concave look. It usually happens if you remove too much cartilage or bone from the septum, or if there's an infection or trauma to the support structures. You usually have to use grafts to rebuild the dorsum and give it support.
Okay, so those are the septal complications. Let's move on to the tip now. Tip problems can really upset patients. What are some of the things that can go wrong?
You can get things like bossy, pinching, and problems with the projection, rotation, or definition. Those can happen for different reasons. The cartilage might be irregular, you might get scar tissue, or the support might not be good enough.
What are bossy exactly and how do you deal with them?
Bossy, those are bumps on the sides of the tip. You can see them. They often happen because the cartilage or soft tissue is uneven. You can try to sculpt the cartilage, hide them with grafts, or sometimes do a combination of things.
I've heard of tip pinching. What causes that and how do you fix it?
Tip pinching, that's when the tip cartilages get narrowed or pulled together too much. It creates this pinched look that's not natural, and it can block the airway too. To fix it, you have to release the tissues that are too tight, and sometimes you need grafts to add volume and support.
What about problems with tip projection, rotation, or definition that show up later on?
To fix those, you usually need a combination of cartilage grafting, sutures, and manipulating the soft tissues. The exact techniques depend on the specific problem and what's causing it anatomically.
Okay, last category then, dorsal complications. These affect the bridge of the nose. What are the common ones to watch out for?
Dorsal complications, you're talking about irregularities, open roof deformity, and that inverted V deformity. They can happen if you remove bone or cartilage unevenly, if there's not enough support, or from scar tissue.
How do you fix irregularities in the dorsum?
You can smooth them out with rasping, cartilage grafts, or a combination of both. The goal is to get a nice, smooth transition along the bridge.
We already talked about open roof deformity. What about inverted V deformity? How do you avoid that?
Inverted V deformity, that's when the ULCs lose their support after you reduce the hump, and they collapse inwards, making the nose look pinched. You can prevent it by making sure there's enough septal support, and by putting the ULCs back in the right place and making sure they're stable. To fix it, you usually need spreader grafts to give support and widen the middle vault.
Besides knowing about specific complications, are there any general principles that can help you avoid them in the first place?
Absolutely. You need meticulous technique, careful planning beforehand. You got to choose the right patients and be open and honest with them. All those things help reduce the chances of complications.
How important is planning and how does that help you get good results and avoid problems?
Careful planning is essential. You need a really good understanding of the anatomy. You have to analyze what the patient wants and then come up with a plan that's tailored to them. You have to think about potential challenges, choose the right techniques, and be clear about what you're trying to achieve aesthetically and functionally.
What about choosing the right patients? How does that help?
Choosing the right patients is huge. If someone has unrealistic expectations, or they have medical problems that could affect healing or psychological issues that could impact their experience, they're much more likely to be unhappy and have complications. You need to screen them carefully and be upfront with them to make sure they're good candidates for surgery.
And what about communication? How does that play into minimizing complications?
Clear and honest communication is key, all the way through. Talk to your patients about what's realistic, the risks and benefits, and what recovery is going to be like. When you're open with them, it builds trust, reduces their anxiety, and helps them make informed decisions.
Revision rhinoplasty. That must be a whole different ball game compared to primary rhinoplasty. What are the main things to think about with those cases?
Revision rhinoplasty, it's often more complicated because you've got scar tissue from the first surgery, the anatomy's been changed, and you might not have much cartilage left. Choosing the right patients and managing their expectations, that's even more important in revision cases.
What do you need to do to make sure a revision rhinoplasty goes well?
You have to really understand the patient's anatomy, what was done in the previous surgery, and how much cartilage you have to work with. Communication is super important too. You need to make sure the patient understands the limitations and potential risks of another surgery.
Any final words of wisdom for surgeons getting ready for the FRCS exam and starting out in rhinoplasty?
Rhinoplasty, it's a challenging field, but it's really rewarding. You have to keep learning and refining your skills. Don't be afraid to ask for help from more experienced surgeons, and always keep trying to get better at what you do, both surgically and in how you care for your patients.
So, let's talk exam strategy. How does really knowing your nasal anatomy and physiology help you make decisions in rhinoplasty, especially those tough cases or when complications come up?
Well, understanding the anatomy and physiology, that's the basis of doing rhinoplasty safely and getting good results. If you know that stuff inside out, you can anticipate problems, choose the right techniques, and tailor your approach to each patient.
Can you give us some examples of how anatomy helps you make decisions in surgery?
Sure. Take the blood supply, for example. You have to know where those important vessels are, like the lateral nasal arteries, so you don't damage them during dissection. And knowing where the nerves run helps you avoid causing problems with sensation.
How about physiology? How does that guide your surgical approach?
Understanding how air flows through the nose and what affects resistance, that's crucial. You have to think about how your surgery might impact the nasal valves, the nasal cycle, and the overall balance of the airway.
What are some key takeaways about the relationship between form and function in rhinoplasty?
It's all about balance. You want the nose to look good, but it also has to function properly. If a patient can't breathe well after surgery, they're not going to be happy, no matter how good it looks.
Any final words of advice for those preparing for the FRCS exam and starting their careers in rhinoplasty?
Rhinoplasty is a complex and challenging procedure. You're always learning and refining your techniques. Embrace the challenge, find good mentors, and never stop striving to improve your skills and how you care for your patients. A solid understanding of anatomy, meticulous surgical technique, and a commitment to lifelong learning. Those are the keys to success in this field.
That brings us to the end of our rhinoplasty deep dive for the FRCS plastic surgery exam. We've covered the essential anatomy, key surgical techniques, and those potential complications you need to be aware of. Remember, thorough preparation, a strong foundation of knowledge, and a commitment to lifelong learning, those are the ingredients for success in this challenging and rewarding field.